So I would be talking about pulmonary hypertension, and what I say beyond, I would talk about it later, and you'll see what do I mean by beyond. Okay, so the first reported case of pulmonary hypertension was in 1891, and from that time till the World Symposium on Pulmonary Hypertension was in 1973, the mean pulmonary artery pressure was defined to be equal to or more than 25 when we call it pulmonary hypertension. Then another 50 years passed, and we reached at a consensus that, okay, apart from mean pulmonary artery pressure, we should comment on pulmonary vascular resistance, which should be more than 3. Another 20, 30 years passed, and we reached a level where right heart cath was added, and mean pulmonary artery pressure was reduced to 20 or more. And now in 2020, when the recent guidelines were published, European guidelines, now we are at the level when right heart cath should be done, mean pulmonary artery pressure should be 20 or more, and pulmonary vascular resistance, if it is more than 2, it is called pulmonary hypertension. So it can be a pre-capillary pulmonary hypertension, isolated post-capillary, or combined pre and post-capillary. In all of them, mean pulmonary artery pressure should be more than 20. Wedge pressure for pre-capillary is less than 15, for post-capillary more than 15, and for combined more than 15. And pulmonary vascular resistance for pre-capillary should be more than 2. For isolated post-capillary should be equal to or less than 2. And for a combined thing, it is more than 2. So in a suspected patient of pulmonary hypertension, why do we do an echo? Because we want to detect and assign a level of probability of pulmonary hypertension. We want to know which group the patient belongs, and we want to see whether there is RV pressure and overload and dysfunction, and that's how we are going to treat these patients. So we have reached these levels, the 20 and 20 millimeter of mercury from various studies, and most important thing is that as we calculate systolic pulmonary artery pressure on echo, we need to know how to convert that level into mean pulmonary artery pressure. So various formulas are there. I personally prefer this one. And more importantly, you need to know that when we say some pulmonary artery levels, they are pretty well correlated with cath data. So we are pretty good over here. So the traditional estimate of systolic pulmonary artery pressure is by TR velocity and right atrial pressure by IVC. So the problem is that there are inaccuracies in estimating the right atrial pressure. There are amplification of errors. That's why the recent guidelines have suggested that we should use the peak TR velocity and not the estimated systolic pulmonary artery pressures. So the key variable now becomes the peak TR velocity more than 2.8 meters per second, because this is going to suggest presence or absence of pulmonary hypertension. So, and how we have reached this level 2.8, that is through this Norris study where all the normals were defined, and we know now that 99.7% of people would have their TR velocities, normal people would have their TR velocities less than 2.8. So that is how we define that. Again, the TR velocity, which becomes a very key variable, there are things which are going to affect that. BMI in older and obese, the cutoffs are slightly higher. Alignment is very, very difficult at times between the CW beam and the TR jet. In atrial fibrillation, there are problems, and severity of TR can be like dense signal or lighter signal, triangular or parabolic. So we can underestimate or overestimate from the TR velocity. And in high cardiac output, we can overestimate. We can misinterpret because of the TV Cloyer artifacts. because of the boundary artifacts. So people who are doing echo very well understand what I am talking about here. So we need additional variables like RV morphology and function to see what are whether we are talking of pulmonary hypertension or not. So these are the various additional parameters. All of you know that when RV enlarged, RV size is bigger, there is eccentricity in diastole, the D-shaped ventricle. That all indicates, like here you see here the eccentricity in diastole. That all indicates pulmonary hypertension. And whenever there is volume overload, there is eccentricity in diastole. When there is pressure overload, there is eccentricity in systole. We also look at the right atrial area. Preferable, although, is that we should do a right atrial volume index. The problems are Butterfly blocks, where we can be really caught in between, and off-axis views may give rise to erroneous information regarding the eccentricity. We have to be careful when there are bigger VSTs and things like that. So, and then we should go and see the right ventricular function. Fractional area change, I think, is the best modality available right now when we are doing routine echo, apart from strain, because strain is the best. Then we can do the TAPSI, we can do the RVS TDI, and of course you can add strain. That would give you the maximum yield. And in a bigger RV where there is small LV, you see pericardial effusion. That is a sign of pulmonary hypertension. Now, this is the point where I say that we are going to do something beyond saying what is pulmonary hypertension and giving a systolic pulmonary artery pressure, because these are some very, very simple things, very basic things. They are going to add value to your report and information, and they are going to add treatment benefits for the patient. So a very important thing is a right ventricular volume, a right ventricular outflow tract acceleration time. This is, you put the sample volume over here, you get the acceleration time and look for whether it is normal or shortened, and look for the notch over there. And a very important key variable is that if this acceleration time is less than 105 milliseconds, this indicates that the mean pulmonary artery pressure is more than 25. So just one parameter, less than 105 RV outflow tract acceleration time, would mean that mean pulmonary artery pressure is more than 25. This is how we measure it. And this is a pulmonary hypertension patient. You see the mid-systolic notch. And mid-systolic notch can be early, mid, or late, and which can indicate whether the patient has precapillary pulmonary hypertension, whether the pulmonary vascular resistance is raised or not, or RV pressure is low or not. Then we go for the early diastolic pulmonary regurg velocity, pulmonary artery diameter, and people who still do M mode can see the pulmonary valve M mode and see if the A dip is lost. That probably means pulmonary artery pressure is very, very high. So the problem is when there is no TR or poor TR signal. And this is, everybody who is doing echo knows that getting a good TR who is aligned with CW signal is rather very, very difficult. There are two very recent studies, one European, one American, and both of them tell us that TR signal or TR velocity signal, you can get about 40 to 60% people, not more than that. So what do we do then? We again refer to this magic thing, RV outflow tract acceleration time. And if it is less than 105, we know that the mean pulmonary artery pressure is more than 25. There are various formulas to convert the mean acceleration time into mean pulmonary artery pressure. If more than 120, we use this formula. Less than 120, we use this formula. So depending on the TR velocity, again, if this is less than 2.8, there are no other signs of PH, the probability of pulmonary hypertension by echo is low. If it is more than 3.4, you don't even require other signs of PH, the probability is high. And there are, these other signs are at least from two categories should be there, from the ventricle, from the pulmonary artery, or from the inferior vena cava. The other things, talking about going beyond the pulmonary artery pressures, is pulmonary vascular resistance, which is a measure of blood flow through the pulmonary circulation. This is how we calculate that. And a very simple formula, you get the peak TR velocity divided by the TVIA of the RV outflow tract with these two constants. You get the results. If it is less than 1.5 Wood unit, it is normal. More than 2, it is abnormal. And like in this case, you see the TR velocity, TVIA of our RV outflow tract, and the result is 6, more than 6 Wood units. It is severe pulmonary hypertension, severe pulmonary vascular resistance. A very good use of this value is especially for the surgeons and for the interventionists when we are about to close the defects. If it is PVR, various studies say that if PVR is less than 2.3, you close the defect. More than 4.6, don't close the defect. And in between, try to reduce the pulmonary artery pressure by various other modalities. And if it is reduced, then close it. Similarly, RV pulmonary artery coupling. This is a relationship between RV and PA during systole. RV and PA should be coupled in that RV contractility should match the RV afterload. And this is kind of a surrogate marker of RV function because this detects very early the changes in RV function. Very simple way to see that, TAPC divided by systolic pulmonary artery pressure ratio. Normal more than 0.55. When you see here TAPC divided by the pulmonary artery pressure ratio, in this case it's 0.56, so very much normal. So these simple things can add value to your report. So when we are reporting, we must report the peak TR velocity. If it is difficult, we can try agitated saline, can raise the legs of the patient and try to see TR. Then the pulmonary artery systolic pressure by acceleration time, diastolic pressure, right atrial pressure should be reported. We must be beware of the fact that we can either overestimate or underestimate the TR and systolic pulmonary artery pressure. Whenever we are seeing patients of pulmonary hypertension, must not forget the left heart function. We can comment on the type and severity of pulmonary hypertension, which group they belong, and additional parameters if they are needed. And most importantly, must comment on pulmonary vascular resistance, RV-PA coupling, and APLAR, which is a parameter of pulmonary artery to left atrial ratio. So TR velocity divided by E prime. And if it is more than 0.3, then the patient is supposed to have precapillary pulmonary hypertension. So with the addition of this, now we can say that the precapillary is when the mean pulmonary artery pressure is more than 20, wedge less than 15, vascular resistance more than 2, then APLAR is more than 0.3. This is precapillary pulmonary hypertension. And similarly, with various figures, we can comment on the type of pulmonary hypertension. So this is one of my patients. I've shown this to various forums as well. She was diagnosed with SLE and she had AST closed about 10 years back. And see here all the classical parameters of pulmonary hypertension, RV volume of load, eccentricity, TR, PR, RV acceleration time, all indicative of severe pulmonary hypertension. And when I did the pulmonary vascular resistance, she was more than 6 units. So in her case, really the question was, because she was having SLE, whether surgery was really indicated, or at that time, probably we missed the pulmonary hypertension. So there are newer modalities. This is my last slide. There is one new blood test is coming up, which is cell-free DNA to tell us about the severity of the pulmonary hypertension. Then there are various newer tests which are going to help us. And again, artificial intelligence analysis of the diagnostic data is also going to be very, very helpful. Thank you.
Thank you, Dr. Shahbaz for the wonderful timing, finishing well in time. If there are any questions, he is here to answer.
Assalamualaikum, sir. I've always had trouble trying to diagnose and quantify pulmonary hypertension when there's a non-coapting tricuspid valve and there's no pulmonary regurgitation as well. Because we know when there's a non-coapting valve, the flow is laminar and there's not much pressure on the TR. And when there's no PR as well, so I know there's pulmonary hypertension, but I have difficulty diagnosing and assessing it. So, any thoughts on that?
The point you have raised is very valid. That is a thing which is very difficult, but the number of cases like this are very, very less. And again, as I have told you, you can go back to the RV outflow tract acceleration time because that appears to be the only solution where you can comment on that. Otherwise, there are certain things which are in the gray zone, so you have to look for the additional parameters and try to get an answer because there are no straightaway answers as per the guideline. So you look for the other parameters, combine the information, and get to the value which you need.
I think in those patients where you cannot get a TR signal, agitated saline is the answer. And you should always use it. It will help you to get the TR signal and you can then see the peak gradient there. That's important. The question which I want to ask is that in patients with pulmonary hypertension, how good is the right ventricular strain? And can we use that? Number
Yes,
two. And secondly, you don't have the software in the machine. Imran may be able to answer this question also. That if you don't have the software, what would you do in that situation? You can use the left ventricular software.
Yeah, Dr. Shahbaz, strain is a very good thing. I've already mentioned that whenever the strain is available, that is very nice. Now, all the recent machines have LV strain, RV strain, LA strain, not RA strain. And we like invert kind of the data of LA strain to get the RA strain. So RV strain is generally available in your machines.
I think they are already beginning to do the right atrial strain also.
Yeah.
And this is being done. The left atrial strain is being done also. And you can use the left ventricular software.
For the RV.
And you can use the left ventricular software if you don't have the dedicated software.
RV strain is not no data just right now, which is very limited.
Yes.
And for just from your 2D echo, you can do strain without having the software. Because
Yes.
it's just the measurement of the length, how much the length changes into systole and diastole. This is the difference that you record. And in some of the machines, Toshiba machines, they have got this facility. Without a strain, they give you the strain value from 2D measurements.
I think the poor man's strain is the MAPC.
Yes. And I think the machine we have out there has all the three strains in that LV strain, RV strain, and RA strain all being done. Salman?
I have one answer to the question just asked that in cases of low flow, how to diagnose pulmonary hypertension. In one thing, Dr. Shahbaz has already indicated activation time. The second thing is to go for and look for the loss of A-dip in the anterior leaflet of the pulmonary valve. And the other thing could be to look for PR jet, right? So when you see the PR jet, the mean PAP you can get.